Hello, it's Dr. Pearlz Clinical Rounds, here with a case on infectious conjunctivitis. Let's get right into it. 19-year-old male with no past medical history and no known drug allergies presents to the clinic with the complaint of right eye redness for 2 days. Patient reports yellow discharge from the right eye and reports waking up today with the eye stuck shut this morning. Patient denies photophobia, blurry vision, eye pain, headache, nausea, vomiting, cough, sore throat, fever, chills, and ear pain. Patient denies wearing contact lenses and denies any trauma to the eye. Patient is not sexually active. Patient has not tried anything for his symptoms. Always ask if the patient wears contact lenses, as this will change the management. Bacterial keratitis is a potential complication in contact lens wearers caused by Pseudomonas aeruginosa. Ask about any trauma to the eye, photophobia, vision changes, severe headache with nausea, and severe foreign body sensation, as these symptoms require an urgent ophthalmologist evaluation. On exam, patient's visual acuity exam reveals 20/20 on both eyes. Vital signs are normal. Patient has diffuse erythema of the bulbar and tarsal conjunctiva with yellow purulent discharge of the right eye. Pupils are equal, round, reactive to light and accommodation. Extraocular muscles are intact. There are no foreign bodies and no abnormal eyelid findings. Left eye is normal. Always perform a visual acuity exam for eye complaints. Examine pupillary light reflex and extraocular muscles. Evaluate for foreign body, corneal opacity, discharge, and follicles. Also evaluate for any eyelid abnormalities such as swelling, erythema, and discharge concerning for chalazion, hordeolum, blepharitis, and/or cellulitis. Evaluate for ciliary flush, redness in a ring around the limbus, photophobia, corneal opacity, fixed pupil, decreased visual acuity, and if present, urgently refer to an ophthalmologist for evaluation for conditions such as acute angle closure glaucoma, infectious keratitis, and/or iritis. What is the conjunctiva? Conjunctiva is a mucous membrane that is divided into the ocular or bulbar and palpebral or tarsal conjunctiva. The bulbar and tarsal conjunctiva are continuous with each other. The bulbar aspect lies over the sclera, or the white part of the eyeball, and the tarsal aspect overlies the inner surface of the eyelid. Conjunctivitis will present as diffuse erythema of the conjunctiva. To examine, gently pull down on the lower eyelid and have the patient look up to inspect the lower tarsal conjunctiva for erythema, discharge, and follicles. You can gently pull up on the upper eyelid and ask the patient to look down to look at the margins of the tarsal conjunctiva. If foreign body is suspected, the upper eyelid will need to be gently everted to fully examine the tarsal conjunctiva. Ask the patient to look up and to the left and right, down to the left and right, straight ahead to the left and right to inspect the entire conjunctiva. If the erythema is localized, consider alternative diagnosis such as episcleritis, pterygium, or foreign body. If the tarsal conjunctiva is spared, consider acute angle closure glaucoma, keratitis, or iritis. What should be in your differential diagnosis for a red eye? Infectious conjunctivitis caused by viral or bacterial causes, allergic conjunctivitis, acute angle closure glaucoma, keratitis, uveitis, episcleritis, iritis, scleritis, herpes zoster ophthalmicus, chemical burn, subconjunctival hemorrhage, and dry eye are all part of the differential diagnosis for a red eye. What features help differentiate viral versus bacterial conjunctivitis? Viral conjunctivitis, commonly caused by adenovirus, may be present with watery or mucoserous discharge rather than pus. Viral conjunctivitis often occurs concurrently with a viral upper respiratory infection or pharyngitis. Patients may complain of burning, irritation, or gritty sensation, and crusting of the eyelids may occur in the morning. Conjunctival follicles may be present, which may be seen in viral conjunctivitis. It can often involve both eyes within 24 to 48 hours of symptom onset. Bacterial conjunctivitis in adults is most commonly caused by Staphylococcus aureus, while in children it is most commonly caused by Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Patients may present with mostly unilateral or bilateral redness and purulent yellow, white, or green discharge. Eyelids can be stuck shut in the morning. There are other potential causes of bacterial conjunctivitis, such as from gonorrhea, which causes hyperacute bacterial conjunctivitis, or chlamydia, inclusion conjunctivitis. In bacterial conjunctivitis, discharge will spontaneously reappear within minutes of wiping. Itchiness is more suggestive of allergic conjunctivitis. What is hyperacute bacterial conjunctivitis? Hyperacute bacterial conjunctivitis, often caused by Neisseria gonorrhea in sexually active adults, is a rapidly progressing sudden onset form of bacterial conjunctivitis that can lead to corneal perforation. Patients may present with conjunctival redness, pain, profuse purulent discharge, conjunctival swelling or chemosis, lid swelling, and diminished vision. Preauricular adenopathy may be present. These patients need urgent evaluation and treatment by an ophthalmologist. What is the treatment for viral conjunctivitis? Topical antibiotic drops have no role in the treatment of viral conjunctivitis as symptoms are self-limited. Warm or cool compresses or lubricating agents can be used for symptom relief. Symptoms will worsen over the first 3 to 5 days before improving, and symptoms may persist for 7 to 14 days or even 2 to 3 weeks. What is the treatment for bacterial conjunctivitis? Most cases are self-limited, similar to viral conjunctivitis. Topical antibiotics may decrease the duration of the clinical course, but the benefits are otherwise limited. The exception is for contact lens wearers or hyperacute bacterial conjunctivitis or chlamydial conjunctivitis. When bacterial conjunctivitis is suspected, contact lens wearers should be empirically treated for Pseudomonas with the fluoroquinolone. Treatment options include erythromycin ointment, trimethoprim polymyxin B drops, ofloxacin drops, ciprofloxacin drops, or azithromycin ophthalmic drops. Ointment is preferred in children if there is concern for compliance or if drops are difficult to administer. Drops are preferred in adults as there is no temporary blurring of the vision, which is typically caused by ointments. Improvement in symptoms should occur in 1 to 2 days. What is your assessment and treatment for our patient? In our 19-year-old patient, symptoms and exam are concerning for an acute bacterial conjunctivitis. Patient has no red flag signs concerning for more serious pathology. Patient also does not wear contact lenses. Patient has no known drug allergies. Patient is prescribed trimethoprim polymyxin B, ophthalmic drops, and preventative measures are discussed. Discussing preventative measures are important in limiting the spread. Conjunctivitis, viral or bacterial, is highly contagious and care should be taken to limit spread from person to person. Frequently washing hands, avoiding touching or rubbing of the eyes, avoiding sharing towels, cosmetics, eye drops, pillows can help limit the spread through direct contact with secretions and contaminated objects. Patients should avoid the use of contact lenses until completion of antibiotic treatment if bacterial and the eye is white and free of discharge for 24 hours. Return to school or work for bacterial conjunctivitis can be recommended after 24 hours of antibiotic topical therapy. If viral conjunctivitis, antibiotic drops will not decrease the spread of infection, and the patient may also have concurrent systemic symptoms. Advise as with any viral illness. That's it for today. Thank you for watching Dr. Pearlz Clinical Rounds. Please hit the like and subscribe button and comment below for suggestions for new content. Let's move on to the next case.